morning, everyone. Today, I'm going to present on the topic of neurosyphilis. My name is Dr. Merina Das, and I welcome you today to my presentation. So, I got interested in this topic because we saw a patient, very interesting patient, who came into the clinic with shooting pains in his limbs, and he had been running from pillar to post to identify the cause of this pain. Interestingly, he was recently diagnosed with HIV and gave interesting history of a past syphilis infection in his teens. So we did the examination and we found that he had loss of reflexes in his lower limbs, loss of ankle reflexes, and position sense, and some sensory loss too. So we sent him for a CSF analysis, and we are following up on the case. And that's how I got interested in this case. So let's dive into the topic. Today's contents of my presentation would be history of the disease, comorbidities, the course of the disease, clinical picture, management, discussion, and will be open to questions. So the history of the disease, as the name signifies, neurosyphilis refers to the infection of the central nervous system, mainly the brain and spinal cord, and it is caused by Treponema pallidum, which is a spirochete, and this can occur anytime after the initial infection, maybe weeks, months, or days. And briefly talking about the history, I would like to say that neurosyphilis has been very prevalent in the 20th century, which is called the pre-antibiotic era. And there, the neurosyphilis was prevalent in 25 to 35% of syphilis patients, where 1/3 had asymptomatic neurosyphilis, 1/3 of them had tabes dorsalis, and the rest had meningovascular syphilis. So this was incline in the pre-antibiotic era, mostly after the post-World War era, and which came to a decline after the advent of penicillin. We saw a decline in the cases until the last 2 decades, where in the last 20 years, there was a resurgence with AIDS. In the last 20 years, there has been 100,000 cases reported to the CDC in the US. So I would like to mention about the outbreak in California and Washington, where there were cases of ocular syphilis in patients with HIV, and many of them turned blind. There was a case series done in 455 patients with HIV and syphilis, and many of them had ocular syphilis. So a significant amount of the infections turn into neurosyphilis. So for the brevity of the presentation, I am concising it to the, I'm not talking about the syphilis infection, but rather I'm focusing more on the neurosyphilis part. So what are the comorbidity and the risk factors associated with it? So as we know, the high-risk sexual behaviors and homosexual people with men having sex with men and people living with AIDS have more propensity to develop neurosyphilis. And this relationship of syphilis with HIV is a bidirectional relationship. Syphilis exacerbates HIV, and HIV exacerbates syphilis. Basically, syphilis can cause inflammation in the central nervous system and exacerbate as HIV, as well as it can cause immunosuppression. HIV can cause immunosuppression, which increases the susceptibility to syphilis. In immunocompetent individuals, what we see is syphilitic chancre provides an entry pathway for the HIV infection. The course of the disease, I would say, begins with CSF invasion. When the CSF is invaded by the organism, it transmits to a stage where it is transient and it clears away. That stage is transient meningitis, when the meninges are involved. And if the organism fails to clear away and persists, it's called persistent meningitis. It then progresses to early disease, which may take weeks, months, or years, and it can progress later to a late disease, which can progress in decades, which takes decades to manifest. So in the early course of the disease, we see asymptomatic meningitis, which is meningitis. We see no symptoms of meningitis, but there is evidence of the organism in the CSF. So basically, at that time, the patient is asymptomatic, but he is able to transmit the infection to other people. So that's kind of dangerous, right? Then we come to the symptomatic meningitis and meningovascular syphilis, which is in the early course, and we'll talk about them in the next slides. Symptomatic meningitis is basically how the normal meningitis manifests. It causes headache, confusion, nausea, vomiting, dizziness. It causes neck rigidity, so we can elicit the signs of Brudzinski and Kernick sign. It also involves cranial neuropathies like optic nerve, facial nerve, auditory nerve. A more significant finding in symptomatic meningitis is the prevalence of ocular syphilis and otosyphilis. So as we talked about it, a lot of HIV people had been seen with ocular syphilis in the past, recent past. So ocular syphilis, how does it manifest? It manifests as uveitis. So the diagnosis can be tricky. Any posterior uveitis and panuveitis mostly. It also causes interstitial keratitis, diminished visual acuity, optic neuropathy, and retinal detachment. So it can cause loss of vision too. Otosyphilis similarly manifests as unilateral and bilateral hearing loss, particularly high frequency hearing loss, along with tinnitus. So the patients have to be referred to the ophthalmologist and the ENT specialist to further evaluate for the causes and keeping suspicion of neurosyphilis in mind if they have a relevant history. So meningovascular syphilis is the infection of the meninges and the vessels, as the name suggests. So the infectious arteritis, which affects the subarachnoid space and the vessels around the brain and spinal cord, that is called meningovascular syphilis. The typical presentation will be a young person with acute stroke. So what do? Do we put them in the MRI machine? Well, yes, as we work up the stroke, we do a MRI and we can see infarcts. In angiography, we can see focal narrowing, dilatation, and occlusion. In many cases, RPR or VDRL may be negative in those cases, which makes the diagnosis a bit tricky at that time. But the history of stroke in a recent young person with a history of syphilis might ring some bells. So coming to the late course of the disease, it is generally presented as general paresis of insane, or general paresis as it is called, and tabes dorsalis. So general paresis manifests as dementia, memory loss, psychiatric symptoms. There are personality changes. The person has difficulty to speak, as well as he shows some neurological deficits like facial and limb hypotonia. And in some cases, there is loss of reflexes. So tabes dorsalis similarly projects as lancinating pain, which is shooting pain, mostly in the limbs. There is due to posterior column involvement, there is loss of reflexes. There is loss of joint sense and position sense, which leads to sensory ataxia. The involvement of the bladder can lead to incontinence, which can lead to mostly presents as overflow incontinence. Agile Robertson people is particularly seen in tabes dorsalis, but it has been seen with some association in general paresis of insane too. But mostly it is a significant association with tabes dorsalis. And lastly, I would say the degenerative neuropathy that occurs with tabes dorsalis is Charcot's joint, where the joints are degenerated and deformed. So here are some pictures of the tabes dorsalis signs that we see. The dorsal column signs where we lose the joint and position sense, and when the patient is asked to stand with the eyes closed, he cannot, he falls off. And in the Agile Robertson people is demonstrated by shining a light to the eyes of the patient, and there is no constriction of the pupils. Whereas when you bring an object nearer to it with accommodation, the pupils constrict. So these are the pictures of Charcot's joints, destructive arthropathy, and degenerative joint disease. You could see how clearly it can affect in late disease. The late disease usually takes decades, 15, 20, or 30 decades, and the incidences of TBs has been declining so far. Mostly with HIV, the asymptomatic and symptomatic meningitis mostly, and meningovascular syphilis, they manifest. So how do we diagnose? So diagnosis is clinical suspicion, and CSF analysis is the key. So what do? Do we put in a needle in everyone's back and spine once they come for a syphilis evaluation? Well, no. The neurosyphilis, the CDC says that the guidelines say that you do not do lumbar puncture in patients who do not have neurologic, ocular, or otologic symptoms. So any patient who shows the signs of syphilis, neurosyphilis, specifically neurological involvement, we do a lumbar puncture. Before that, we can do a screening test with non-treponemal tests, the VDRL, RPR, etc., which are not very specific, and they arise. There may arise some false positive results too. So we do the non-treponemal tests, which are very specific. These are the fluorescent antibody absorption test, FTA, BS, and enzyme immunoassay. So basically, if a patient who shows signs of neurosyphilis, we do a LP and we do the CSF treponemal antibody tests for analysis. Alternatively, we can do an MRI also if we suspect meningovascular syphilis. So now coming to the management, how do we manage these cases? As we all know that there is a miracle drug for syphilis, which is IV penicillin, but the duration is important. We have to give it for 10 to 14 days. And US recommends 3 to 4 million units IV every 4 hours by infusion. So what do we do if a patient is penicillin sensitive? So do we go for alternatives? Well, no, we desensitize because penicillin has the highest efficacy here. So we desensitize the patient and then we try to give him penicillin. So in some cases, when we couldn't desensitize, we can use alternative therapies like ceftriaxone or doxycycline. The duration is important. We again have to give it for 10 to 14 days. And doxycycline we give for 21 to 28 days. And we have to monitor those patients. How do we know that the person is disease-free? We monitor by, after 3 to 6 months of therapy, we start monitoring for a 4-fold or greater decline in the titer of VDRL or RPR. So basically what we do, when we start the treatment, we do a lumbar puncture and we see the titer. If it is 1:32 around, and when after 3 months, we look for titers, and 6 months, we look for titers. If they have declined 4-fold, like 1:8, it has become 1:8 or lesser. So in these cases, we do a follow-up for 6 months, every 6 months, till the CSF is free of the organisms. We also see lymphocytosis in the CSF in neurosyphilis and increasing protein. However, those are non-specific. We can monitor for an important reaction that occurs during spiritual infections within the 24 hours of the treatment, which is called the Jaris-Husheim reaction, which presents acutely with headache, chills, fevers, myalgias, rashes, etc. And this is generally self-limited and treated with supportive therapy. Well, coming to the end of the slide, I would say we come to the discussion. I would say this there's a sufficient stigma relating to the disease. Earlier in the past, uh, there have been many poets, intellectuals, artists like Van Gogh, Keats, even they say Columbus and Shakespeare have been infected by this disease. And they resorted, many people resorted to erratic treatments, which also incurred mercury poisoning in some cases. So today too, these stigmata remain, which leads to delay in the treatment, delay in follow-up, partner notification, and wide range screening. So I believe the stigmata needs to be dealt with. Then I think the false positive VDRL and RPR leads to a delay in treatment and detour, which creates an unnecessary delay. We have to devise strategies and effective investigations which will be dealt in these matters. There are very few alternatives in these syphilis treatment. The only one major drug is penicillin, and the desensitization process takes very long. So in patients who are allergic to syphilis, they are held at bay. There is a delay in treatment, and the infusion is quite long. So it's a long and tedious process, and there needs to be better alternatives, and more research needs to go there. That is what I feel. And particularly this is important because there has been a global resurgence of syphilis, which has increased from 1990 to 2000. Because after 2000, because they have had so many cases, more than 110,000 cases, which were reported to CDC. So we need to do something about this, and we need to have some more research and newer drugs regarding this. There's a study by Melody et al., which points to the unique challenges and diagnosis and treatment. And they also propose a various factors which we can inculcate in our research, like prevention and pre-exposure and post-exposure therapies for both HIV and syphilis, which can be a good read too if you want to know more about the topic. So that is it for today, and thank you for listening to me, and I'll be open to questions. Thank you so much.
Okay.